Well, it's a pleasure of mine to have Dr. Jarushka Naidoo again on the podcast. We taped the podcast episode prior to Worldline. We had a chance to meet at Worldline. And I had invited Dr. Naidoo to really talk about the differences in cancer care when it comes to treatment, diagnosis, and clinical trials across the continents. Because sometimes I feel we are in the US living in a bubble and we think everything around us is very similar. But you have a very unique experience where you practice, where you're from, what you're doing right now. So I really feel very honored to get you again, but I'm looking forward to really learning a lot from you. And I'm sure my listeners are going to learn a lot. So let's get started by, again, a brief introduction as to who you are and where you are, and how did you really become this well-rounded, because you had a very unique experience as you traveled all over the world.
Well, citizen of the world. So yes, I'm South African, proudly South African, but trained in Ireland, did all my medical school and oncology training here. And then the Irish often send their trainees to finish off their training in the US. So I completed my training with a fellowship at Memorial Sloan Kettering, where I worked with Jed Walchok and Naya Rizvi on immunotherapy and lung cancer. After that, I joined the faculty at Johns Hopkins. And I was there for 6 or 7 years as a assistant professor, where I developed an interest in immunotherapy clinical trials and immune-related toxicity. And more recently, I've returned back to Ireland, where I trained, and I'm chief of thoracic oncology at one of the major cancer centers here, and chair of the National Clinical Trials Group for Lung Cancer, Cancer Trials Ireland, and a part of some of the European cooperative groups, for example, ETOP. So yes, I think I have a unique experience that I've worked with in various jurisdictions, and appreciate maybe some of the differences in how cancer care and clinical trials are delivered, particularly in Europe, US, and to some degree in Africa.
So you're literally, Jarushka, you're literally the perfect guest for this episode. Okay. So here, the way I'm thinking we're going to divide this, just to kind of explain things to listeners. We'll go through diagnosis, treatment, and then clinical trials. So when it comes to diagnosing cancer, what is available and not available between these three continents? I mean, whatever you can comment on. I mean, can everybody get a PET scan? Can everyone, whatever it is, because obviously this is important. And part of the diagnosis, which I wanted to comment on, is pathology, right? I mean, NGS or whatever type of, staining we're doing. So can you take us through the diagnostic piece? Because, maybe Hopkins different than Ireland, and how are you coping with the lack of certain tests that maybe you took for granted in the US?
Yeah, let's use, obviously, I'm a thoracic oncologist. We can use lung cancer as an example. I think these pathways are very different, and truthfully, they're very different in places within the US. And I think that when you compare academic clinical practice to community practice in the US, it is very much like comparing to different parts of the world as well. So certainly at Hopkins, we had a lung cancer multidisciplinary clinic. Patients got their diagnostic workups through the respiratory or pulmonary physicians, and we would not have actually had an in-house NGS platform beyond the standard, hotspot testing panel. So we would have sent externally for Foundation Medicine or Guardant at that time. And that was a little bit different to Memorial Sloan Kettering, where I was a fellow, where there was, of course, the in-house MSK impact assay. So even within two academic institutions, a little bit different. Even within places in the US, I think as PD-L1 came into being, the workflow around which PD-L1 assay to use, the interpretations, I think all of that, oh, there's Marina, was something that we saw very differently in different parts of the US. And then in Ireland, I think similarly, the trying to bring in a national system by which PD-L1 testing, NGS testing is similar, in different institutions across a country, and a national health service is, of course, the challenge. In Ireland, we have 8 cancer centres, and some of them will service some smaller units. And standardizing how some of that NGS testing is done, I think, is obviously an ongoing challenge, particularly as we become interested in more and more molecular markers. We have 2 nationally supported molecular laboratories, so most of the samples would centralize to those 2 molecular laboratories and have a fairly standard turnaround time. But I think some of the challenges, of course, are trying to incorporate new markers as standard care in real time, and to make sure that our patients get a broad panel of NGS testing when drugs are available, either as part of standard of care, expanded access, or even clinical trials. So some differences there. I recently returned to South Africa to give a talk at sort of one of the national meetings. And my understanding is that there is quite a disparity between the public system and the private system, where really the private healthcare system, certainly in South Africa, is very akin to Europe or the US, where commercial NGS testing is available and is sent out as a commercial assay. But in the public system, really there is no access to NGS testing at all. So quite a disparity there. Marina, maybe I should let you jump in.
Yeah, no, that's actually excellent. So Dr. Marina Garassino is an excellent additional guest for this podcast episode. So Marina, I know we started a little bit before you were able to join us, but we're starting by just doing some introductions so listeners at least could know a little bit more about you. And I think what's unique about having both of you on this podcast is really trying to understand the differences in terms of diagnosis, treatment, and clinical trials between Europe and the US, because we do take certain things for granted in the US, assuming that everybody else have the same. But the reality is you've practiced in both continents, so you have a very good visibility into what happens and not. But just before you give us a little bit about the diagnosis, a little bit about you, and how did you end up back in the US?
Yeah, it's a long story. So my daughters wanted to study in the United States, and so I started to consider the idea to move, and I'm here. And they are both in New York. They are one is finishing the Parsons School of Design, and the other one is doing the NYU. They are already graduated in Italy, one in design and the other one in philosophy. And so they are doing a graduate program here in the United States. And so they are basically my family. And we moved.
And before you came to the US, and you're currently a professor at the University of Chicago.
Yes.
Just for listeners who don't know you, before that, where were you practicing prior to that?
I was the director of the thoracic program at the National Cancer Institute in Milano, which is the oldest cancer center in Italy, and I think one of the oldest also in Europe. And I don't know if you are familiar, but Bonadonna, who invented so much of the chemotherapy for breast cancer and also for the lymphomas, was there, and it was exactly in my same floor. So,
wow.
Yeah, and Veronesi, who invented the quadrantectomy for the women for breast cancer, was there. So it was a very old and academic institution. So
amazing, yeah. Amazing. So we started, before you were able to join us, we started talking about the diagnostic piece. And
okay.
what I asked Jarushka is, when you are faced with the diagnosis and staging and figuring out patients with thoracic malignancy, we're using this as a platform because you're both thoracic oncologists. What differences can you share with us? Is everything available in Italy? I mean, whether we're talking pathology, we're talking PET scans for everyone, and they can get that done next week. Whether NGS, I mean, what have you noticed any differences?
Yeah, so basically the systems are really different because in Europe in general, we don't have insurances, and we have an universal coverage of the health system. So you don't have to pay for anything. And this is the biggest difference between the United States and, I would say, Europe, because all Europe is very similar. similar also to Canada. I think that is also the reason why we see always Canada and then Europe together, and then the United States. And so the big difference is that there is a good part of the story and the bad part of the story. The good part is that you can be the richest person of the country and you can be the poorest person of the country and you receive exactly the same treatment. The negative, and the same for the diagnosis. The negative part of the story is that it takes more time, for example, to have the drug approved. And sometimes there is the EMA, which is lower compared to the FDA, and sometimes there are also different outcomes that they approve. For example, in Europe, they approve things only based on the overall survival, and in the United States, they approve things also based, for example, on the progression-free survival. And so clearly, this situation will create not, I would say, not delays, because we saw things that were approved in the United States and then they failed to have a survival benefit. But clearly, the process is different. And then there is a negotiation for each member of the Unite from EU, from Europe. So Italy will negotiate the price and the strategies. Germany will do the same. So all the member states negotiate the price, they negotiate the indications for the pharma company. And the process can take much more time than in the United States. So in the United States, you have everything available tomorrow morning, and in Europe, but you have to pay. In Europe, you have everything available like in 1 year, and you don't have to pay. So I don't.
But for cancer patients, you obviously they can't wait a year. So let's start by a cancer patient that is seeing you in Italy. Can you get a PET scan to stage that patient within a week?
Yeah, so the big difference of the staging is that we do much more PET scans in Italy compared to the United States. And we do always also the exam of the brain. So for all patients with lung cancer, we do a brain MRI and we do a PET scan, basically. So, and sometimes we use also the PET scan for the restaging. Here is much more difficult to have the PET scans and to have the brain MRIs and also the CT, the head CT. So it's more complicated. You need to have the approval of the insurance, while this part in Europe in general and also in Italy is a routine.
And there's no wait. And Jarushka, for the PET scan we talked about in Ireland, there's no wait. You can get that done for a cancer patient, or either in South Africa there's wait, or there's a.
So I think maybe that's touching on maybe some differences within Europe. Definitely in smaller countries, we certainly have a wait for a PET scan. So there are only selected institutions that actually have a PET scanner, and obtaining a PET scan in a certain time frame is a challenge. And there are some sort of strategic agreements between hospitals in obtaining them. Having said that, I think the workup is a lot more standardized, as Marina says. So we do get PET scans on every single patient pretty much at baseline, and brain imaging baseline with a brain MRI. And I think that also points to the fact that, say, we only have 8 cancer centers in the whole country. All of us have done fellowships either in the US or the UK. We're actually very similarly trained. So that variability in what, in how we approach things is minimal, as we've been trained sort of the same way. But access is certainly an issue, but I think we all ask for it, and we do get it, even though we have to wait.
Have you had to start a patient, Jarushka, on treatment without complete staging?
No, I won't do it.
So that no, I mean, that's because that tells me the wait time. So now in lung cancer, my understanding when I was in training, by the way, there was only 2 lung cancers, non-small cell lung cancer and small cell lung cancer. Now there's about 55 or 500 lung cancers. So we talked a little bit about the molecular profiling and the importance of dividing the the lung cancers based on driver mutations and so on. Marina, how are things in Italy? I mean, you can't manage lung cancer today without having access to all of this molecular information. Was that easily accessible? You could do that, either send out or local, and you get the information in time?
So in Italy, there is a big difference among the cancer centers and the small hospitals. So the cancer centers, basically, they do exactly what we do here at the University of Chicago. There are no differences. The smaller centers, they have to send the samples to bigger institutions. And so they have worse timelines compared to other institutions, so compared to the cancer center. I think that the best was done by France. I don't know if you are aware. So they created a lot of centers that they do the testing for all the countries. So the quality of testing is very high. And if you live in a smaller center, you have to send the tissue for the for testing in a hub center. So basically, they created a sort of system hub and spoke that work very well with a very high quality. So I believe that from what I see, this is the best that I saw in Europe.
In Ireland, Jarushka, you mentioned something about that a little bit.
Similarly, so we have 2 central government-supported molecular laboratories that aim to sort of have the highest quality, the most up-to-date panel. Having said that, there is still some variability. Sometimes the smaller centers, you know, or in certain circumstances, tissue may not get sent to the central lab and something may end up being done locally. So there is still some room for variability, but there is the same national structure that Marina mentions.
So what I want to summarize the piece of diagnosis, because we hear a lot of things in the US that patients could wait a year for something. And I get that for elective stuff, right? If you may want to have like a hip surgery, I guess it's elective. But for the patients with cancer, it appears to me that they get their similar staging. It's timely, and you get the molecular testing for lung cancer, which is timely. Like you have not noticed huge difference, right?
No.
From a diagnosis. Okay. So maybe the treatment then is where the variability is, because I think Marina mentioned that some treatments are not available, and here they are accessible because the FDA approved different threshold. Is that in Ireland? Like, where's the Ireland fit with this?
So I think one of the diagnostic challenges, certainly so far, is we do not yet have access to liquid biopsy for all patients with newly diagnosed non-small cell lung cancer. So right now, we do liquid at the time of acquired resistance in certain subsets of oncogene-addicted lung cancers. And that is perhaps a difference between being in a large US center and here and having to do sort of a small pilot study to demonstrate that this shows a reduction in time to treatment. And certainly similar studies are being undertaken in the UK as well. And I think that also points to a challenge of a smaller country is the absolute number of molecular pathologists that are out there to do a volume of liquid biopsy. We would certainly have to invest in those people in order to scale up to allow for all lung cancer patients to have this. So I think therein is a difference. In terms of treatment, certainly the reimbursement pathway, and I'm sure Marina will probably enlighten us about other places in Europe as well, because this is a national system by which the country or the government tries to approve a drug such that everybody in the country may have access to it. There is usually a complex negotiation with the pharmaceutical company and the government to try to obtain a standard price for this medication that could be delivered to all patients. And that usually is a step that takes some time. Obviously, there are differences in places in Europe. The UK now has a novel link with the US called Project Orbis that allows this to be done a little bit quicker. But certainly in Ireland, that is something that affects how quickly we have certain drugs available to us.
So Marina, as you comment on that, I wanted to separate IV from oral therapies because I don't know, maybe there's a difference, maybe not. I mean, I'm assuming that if you're doing carbotaxol, is very different than if you are prescribing crizotinib, I guess. I'm just throwing names here. Is there a difference in terms of delivery if it's one of these novel therapies versus IV therapy in terms of coverage and reimbursement?
No, when the drugs are approved in Italy, they are approved, they can be either oral or IV, and you can do whatever you like. If they are not approved, if you want to administer the drugs that are not approved, they must be at least approved by EMA, and the patients can pay for the drugs. So that is something that does not happen very frequently. So, but there is no difference between drugs, oral and IV. It's just a matter of approval.
And then the government, the healthcare system takes care of paying for IV or oral. It doesn't matter. So the patient does not pay anything out of pocket.
Exactly.
They will come in and they get the pills and go home, and they pay nothing whatsoever.
Exactly.
Is that the same in Ireland?
Yeah, so it's very similar. So definitely for IV therapies, that's the same. For certain oral therapies, they're delivered under something called a high-tech drug scheme. And there may be a standard small amount that is paid as a once-off, but certainly something that would be within reach of any citizen of the country.
So let me ask you a question then. I mean, Marina, you were in Milan and then you came to the US a few years back, a couple of years ago. What was the biggest, I don't know, shock or issue that you dealt with? I'm going to ask the same question for Jarushka, but the opposite way. But like, what did you deal with that, you know, I don't know, like you were very disappointed or upset or frustrated that you were fine with in Milan? Is there such a thing?
I think the disparities. You know, when you are in Europe, you can't imagine what are the disparities, because basically Europe is everywhere a social environment. And here there are super rich people and super poor people. And for the poor people, I'm struggling all the time, because maybe you can have also, you know, the drugs approved, and these people, they don't have the money for the public transportation, so they have a food insecurity, they live alone. So there is a complexity which is not drug related that I believe that at least in Italy does not exist.
But so in Italy or in Europe, you don't have some patients who there are poor people, I presume.
Yeah, there are poor people, but you know, there are first of all, there are no co-pays. They don't have to pay for the treatments. They don't have to pay for additional things. So because everything is totally free. And then I believe that I really don't know why, because clearly Italy is not a super rich country, but there is a social tissue of the society for which the people take care of the other people. So, for example, if there is in the building a person who is sick, there is always somebody that can bring this person to the hospital, that can help. So I think that the way how we live is different.
So that's, you know, there's a sense of community, I think, what you're referring to. So the first thing that shocked you, I guess, if I'm understanding correctly, is the disparities, where you feel, Jarushka, you were here, you practiced at Hopkins for a while, and then you went there. What did you sense?
Well, I trained in Ireland, so I was used to the Irish system, and I suppose I had culture shock to America, and then maybe reverse culture shock in coming home to some degree. I think in coming to the US, I started at Memorial Memorial was very much a different environment, perhaps in a sense more of a commercial environment, and people came, for an opinion. They may or may not have been from New York, and there was a sort of sense of commercial choice about where you went for your treatment. And I was Jed's fellow. Jed won't mind me saying this. I was very much told, "You're not Jed. Where's Jed?" So, which was fine. People came to see him, and that's kind of how it was. And similarly, at Hopkins, to a certain extent with Julie. But I think there was that sort of sense of choice, maybe, and in the US system, because it's a big country. But of course, as Marina says, choice for certain folks, and others maybe not so much. And you definitely saw that difference in the social fabric, that sort of gap between maybe the haves and the have-nots, and certainly something that, as an African growing up in apartheid, I would have seen before. But I think in coming back to Europe, certainly there is that, sense of community. There is that standardization. I think the other thing that's very obvious in practicing between Europe and the US is acceptance of palliative care. So, when we bring up things like supportive care alone, hospice, often that is very welcomed. And that is often seen as the community coming together to support their older folk or those who might need additional supports. And I learned very quickly in the US that palliative care was a bad word. And that the word hospice was wasn't received very well, and had to be couched in a certain way or drip fed. And I think that again perhaps points to some cultural differences. And there is certainly an appreciation, I think, now in the US as well, that this is something that can help our patients regardless of where they come from.
Yeah, I fully agree. I think that this is another very important point. Another thing that is very so different, I believe, from Europe is that here, I see patients 92 years old that they want to be treated. And in Europe, so there is a sort of acceptance that at a certain point your life must finish. And here I think that there is more, also the families, is pushing for overcoming boundaries. And, I have a clinic of sometimes of patients that are 87, 90, 91. So that it's totally different from what I had.
But let me push back and ask you a question, Marina. So let's say a 90-year-old comes into your clinic in Italy when you were practicing in Milan. Are you going to say, "I'm not going to treat you because you're 90, or you're still going to treat and you assess clinically and so on, right?
No, yeah. So there is the idea that the old people are biologically old and
Right.
not just anagraphical old. So, but when you are, for example, 90 and you go to a third line of therapy, maybe you say no in Italy. And here I see that there is a continuous request to continue to have these patients alive. And there are no data if we are doing something correct. And I think that for these people, the quality of life must always be the most important issue.
I do agree with the cultural notion that you both did, and I also come from a different part of the world. I've been in the US for 30 years, and the cultural aspect of wanting to push as much as possible is definitely more palpable in the US. There's less acceptance to the end of life issue, which should take me to, we talked about the palliative care. Let's talk about two other aspects, and then I promise I'll let you get off the call. But one is clinical trials. I think that clearly, a lot of the trials I see in the thoracic world sometimes are held globally. But take me through clinical trials and what have you noticed differences between Europe and the US in terms of whether it's investigator-initiated studies, or are there cooperative groups that you participate in or pharma-sponsored? What seems to be the palpable differences? We'll start with Jarushka and then go to Marina.
I think Marina has a major depth of experience here and will definitely be able to teach us a lot. I think certainly in my experience, I was privileged to be able to write and run some investigator-initiated studies at Hopkins and participate in some of my colleagues. I think the clinical trial portfolios, as they are in many different jurisdictions, usually are predominantly pharma with some smaller numbers of investigator-initiated studies and cooperative group studies to pay the bills and to make sure everything balances. And that's certainly something that we see here in Ireland as well. I think major differences, again, are related to the size of the population. That within the US, people might travel quite a lot for treatment. They might get on a flight for a clinical trial that is available in one area versus another. That is something that is probably done a little bit less. Certainly where I live or where I see people might be less inclined to travel unless they felt that it was for a new option, and even traveling would just be driving in most instances. I think because the population is smaller, again, our choice of clinical trials might be a bit different, tailored to the population that we see. And again, the majority of our clinical trials would be pharma-based studies, but getting involved in cooperative groups, expanding some of the cooperative group studies, and then having at least one or two investigator-initiated studies, I think is important. I think a lot here as well is maybe a change in how clinical research is being done, that doing cooperative group studies or these kinds of studies are becoming more difficult in terms of the funding model. So we are seeing that maybe our trial portfolios have a few less of these. But again, I think as an old-fashioned academic, I think they're very, very important, and that there are certain questions that will be tackled by an academic study that won't be tackled, for example, by an industry study. So certainly in creating our trial portfolio, I think it's very important to have a nice mixture of these different kinds of studies. Marina, I'm not sure what you think.
No, I fully agree on what you said. I think that in a certain way, I feel that doing research in Europe, it's strange to say that is easier than in the United States. Because there is, so the clinical trials are the clinical trials, but sometimes to open a clinical trial, I think that here there is more complexity than in the United States. And I think that the timelines of opening the clinical trials, not at the University of Chicago, I think in the United States sometimes are really long. I think that on top of that, there is the problem that there is after the pandemic, that now all the people, they want to work remotely, and the people, if they want to work remotely, they just have to go in the pharma companies, because if you work in the hospital, you have to stay in the hospital with the patients. So I think that from what I see here in the United States, there is a huge number of patients that are people who are leaving the academia and they are going in the pharma companies. And this can create a huge problem for the academia, because if we have too much shortage of personnel, we can't run anymore the clinical trials. And if we can't run the clinical trials, we don't have a generalizability of the results of the clinical trials, because you see, if you look at the enrollment in the last years, all the enrollments are basically done by Europe and also in the eastern part of Europe. So also in Europe, there are some differences. There are many patients coming also from some Asian parts, and the enrollment of the United States, which is the biggest country, is not so high as in other countries. So I believe that here we have to think how to use better the personnel and how to simplify more the access to the clinical trials. Then there is a second consideration, which is that in Europe, we don't have so many biotechs like in the United States. And so here you can have more access to, to compounds that maybe we see in Europe only when they are bought by big pharma companies. And so you have more exposures to novel compounds that can be maybe interesting for the future, and they are just in small companies. And the third consideration is that here the situation from what I see in the United States, and that maybe Chicago is not, is different from Texas, is different from California, is different from other states, is that there is, in some populations, there is a lot of skepticism to participate to the clinical trials. And I refer in particular to some populations, and I think that we have to improve the education and to see that we do something for the patients and not against the patients.
Is it where is easier to get funding? Because the pharma sponsored is different. They're going to pay for the trial. But when you're an investigator, Jarushka, which one is easier?
I suppose that, truthfully, I haven't been at home long enough as a trialist to be able to say if it's easy or difficult. But so far, I must say I found maybe I was just lucky, but the funding model and getting a couple of investigator-initiated studies, I found that at least surmountable in the US. Obviously more difficult, but certainly I had a relatively good experience. And now in returning to Ireland, a few studies are coming on stream, but perhaps it is a little slower. I think the other consideration in the EU is the regulatory environment. So we do know that in 2018, the EU published the GDPR regulation, so the General Data Protection Regulation Law, which is basically the strictest privacy and security law around data in the world. So the practicality of opening some clinical trials and clinical research studies across Europe increased in its complexity after the introduction of GDPR, and certainly different European countries' interpretation of GDPR is slightly different. And that does sometimes provide some increased level of complexity to opening studies and doing things appropriately in Europe.
Yeah, I think that this is a crucial point. I don't know if you are aware, but the privacy laws were created when there was the Snowden case and there were the phone interceptions of Merkel. And they wrote the privacy law and they didn't take into account that the health system or, for example, also the registries were exceptions to the privacy laws. So the situation changed thanks to the ESMO, that is the European Society of Medical Oncology, who grouped all the most relevant scientific societies in Europe, and they were able to change the privacy law with written one-time consent. So potentially the patient can just sign a one-time consent, for example, for the use of the personal data and whatever. But the problem is that it's always difficult, as she said, to share data, and you have to reconsent the patients. For example, if I want to corroborate with France, we have to create specific agreements for the privacy. The patients must be reconsented with all the people who are taking care of the data. And what is, again, even more complex is now that the member states, they can shape the privacy laws according to their practice. So it is possible that in the future, France will be different from Italy, will be different from Spain, will be different from Germany, and there will be a lot of complexity to do European trials. And also, when I started to do the Teravolt, that was a registry of COVID and cancer, was a nightmare for me to organize the privacy for the United States and the Europe together, because the laws are totally different.
Wow, this is fascinating to me. I mean, I'm listening to this.
It's a disaster. It's not fascinating.
No, it's fascinating in a way just to learn. I mean, this is really very, very challenging to hear these differences. Well, I want to finish with the last few minutes is more about the physicians and the lifestyle and quality of life. We hear a lot in the US about burnout. Whether, how much burnout is and how you define burnout is in the eyes of the beholder. You both have worked in those systems. Tell me how, as a physician, as a healthcare professional, which system you like more. You can have a good quality of life. You can have a life balance. You're not, running 100 miles an hour. Marina, let's start with you.
Yeah, it's really difficult to say. So, because I believe that in the United States, there is much more bureaucracy compared to Europe, at least from what I see. The notes are really painful for my life. And the billing system is really painful. So sometimes I don't know why I have to spend so much time instead of doing research to do this kind of things. So I think that this part can really burn out the doctors, because it is a lot compared at least to Europe. The good part that I like of the United States is that in Italy and in Europe, maybe the UK is just a bit different, but the nurses are just administering the medicine, the medications to the patients. So they do not have an active role in the treatment of the patients. And here, what I like a lot of the system is that there are the PAs, there are the nurses, the research nurses, the advanced nurses, there are multiple levels of nurses. And so you have much more help on taking care of the patients. For example, I don't have to take care of gemcitabine day 8 because the PA will take care of this, and I have much more time to give more indications of treatment to the patients. So on one side, they use in a proper way my work and my brain to give indications. On the other side, they use my work to do the terrible notes. So
do you feel in aggregate, do you have good family balance?
I think that I'm workaholic, and so I work 24 hours a day in Italy and the same in US. But I have 2 daughters that I think that they are quite well grown up now. And I can sail, I can do vacations, so I can find my time for my life. I think that all the doctors work a lot everywhere.
Jarushka, I hear, except in Ireland, they're having a great time there.
Well, you're also talking to a workaholic here, so maybe you just picked 2 wrong people. But I think what Marina says is absolutely true. Certainly in working in the US, I think some of the administrative requirements, the prior authorizations, the notes, they can be quite time consuming and heavy. I think the other thing that's quite obvious in the US is the email culture, that you are constantly on your email, and there really isn't such a thing as vacation. That even when you're on vacation, you are sort of accessible on your email, and there is this replying to email even on vacation. That is certainly not true.
I don't put out of office note anymore.
Yeah,
I don't.
So that's quite a difference, because I think when people are out of office here, there's quite a respect for that, and there is a respect for the need to recharge, and that one needs that time away from one's email. Having said that, I think in Europe, with a national structure, sometimes in trying to get that access to everybody, there might sometimes be less investment in some critical infrastructure. So in general, there might be, exactly as Marina says, less nurses or less mid-level providers on the ground to support some of the critical clinical staff. And that can mean that potentially Europeans can burn out from a lot of heavy lifting clinical work, rather than maybe some of the technical aspects. However, thankfully, when we're on vacation, we're on vacation. So I think it's a little bit of both.
How many weeks of vacation do you get a year?
So quite a lot more than the US.
Okay.
So
how many?
It's 4 to 6 weeks of vacation a year, which is considerably more than most places in the US, I understand.
Yeah, Marina, how many weeks did you get?
Yeah, when I was in Italy, I had 6 weeks. Here I have 5 weeks, which is great, but I can't take so many weeks. So I see that I think that in the last year I made 3 maybe.
Yeah.
I fully agree that we can be burned out in different ways in the situation. I think that in Italy I was burned out for the incredibly massive clinical work. But I have just to write patient in CR, continue the treatment, full stop, and go to the next patient. Here, for something that can be summarized in 2 lines, I have to write 2 pages.
Yeah. I mean, given everything that we talked about, my literally last question is, Marina, would you have come to the United States to I want to take your daughters out of the equation, because I realize family, obviously, there's sometimes we do certain things because there's family pressure. I totally get that. If your daughters did not want to come to the US, would you have come to the US to practice now that you've been here for several years and you have an idea, obviously, how things are? And I also want to try to tell Jarushka, assuming she wasn't from Ireland and now she's in Ireland, would she have gone to Ireland? So Marina, would you have come to the US now that you've been here for a couple of years and you know how it is here?
Yeah, I would say yes, because I see a totally different system. And I see that my brain is working more and thinking more than before. If I was in Italy, maybe I was in my comfort zone with my fabulous group, with my language that is still terrible. So I was in my comfort zone. I couldn't see different ways to approach things. So I would say yes to go out from my comfort zone. I think that there are pros and cons for each system, and I can't say if one is better to the other. Maybe I can tell you in a couple of years more.
Jarushka, would you have gone back to Ireland?
You're going to get another politician's answer. So, you know what? I think big picture, it's just about the opportunity to do great work. And the truth is, you can do great work in Europe and you can do great work in America. And really, we are a global community. Look at this call. And every time, as you said about World Lung, it actually doesn't matter where you sit, as long as you work with good people and you ask good questions and you never forget the question and the patient. So I'm happy wherever I am.
I think that this is a great point. And my experience during the pandemic was that I was able to create this registry of 220 centers around the world, because we are a community of people who are friends and we help each other. So it's not important that I am in the United States. Now it was exactly the same when I was in Italy. I think that the relationships among the people, they are the most important thing to work well.
Look, I'm very grateful for your time. Thank you so much. This is great. I hope listeners can appreciate the differences from a patient perspective, from a physician perspective, and I look forward to seeing you in person very soon. So thank you, Dr. Jarushka Naidoo and Marina Garassino.
Thank you for inviting us.
Thank you.